Dr. Mistovich is going to come up and give us his thoughts on sports injuries in the growing athlete. Thank you.
Good morning, everybody. Thanks for the opportunity to spend some time with all of you. Thanks for all you do for our community. So athletes get hurt all the time. This is a photograph that I took Monday night. Put my name on the wait list for Steelers season tickets when I was a freshman in college, and dreams finally came true 2 decades later. But nobody wants to see anybody get hurt, especially this way. So we take care of athletes on the sidelines the same way, but the way that we take care of kids versus adults is a little bit different. And kids and teenagers are really not little adults. And a couple of the reasons why is that kids have growth plates, the physis, the area where the bones grow from, and this is actually weaker than the ligaments and the tendon insertions in the bone. Kids have laxity of their ligaments, so they're able to dislocate their patella or their shoulder a little bit more easily than an adult is. And this has some benefits. Sometimes it's less traumatic because they have ligamentous laxity, but sometimes it's easier for it to pop out too. Their cartilage, the coating on the bone, and the periosteum, the coating on the bone, is a little bit thicker, so that impacts the way injuries happen. And kids are also in different phases of brain development and muscular control, so their injury patterns and their risks are a little bit different as a function of that. So here's the plan. First of all, it's important to know your audience. So how many pediatric orthopedic surgeons do we have here? Probably one, right? Right. So we're not going to spend some time going into the nitty-gritty detail on how we do these surgeries and the surgical techniques, but my goal today is, how many EMTs do we have in the room? Great. So you guys are the front lines for these injuries, whether you're at the sideline or taking kids from their backyard to the hospital. So the stage that you guys set for injuries and the public health difference that we can make is pretty huge. Pediatric orthopedic surgery is a relatively new field as it is compared to some of our other disciplines, but pediatric orthopedic sports is very new. And there's opportunities and there's challenges that come from this. So there's a lot of injuries that have been historically neglected, especially as we think about some of the communities that we have here in Cleveland. There's injuries where coaches, like patella or shoulder dislocations, where they say, oh, this is just normal, happens to some kids, just play it off. But that's not necessarily true. So if we can help you guys sort of set the stage for these injuries and some of the treatments that are possible, I think we can, from a greater standpoint, improve the public health overall of our community. So we're going to talk about ACL ruptures and how kids are different. We're going to talk about tibial spine fractures, and this is when the ACL doesn't tear, but actually pulls off of the bone, off of the tibia. Patella dislocations and instability, shoulder dislocations and instability, and then just some quick thoughts on returning to play if we have time. So let's start off with the case. Here's an 11-year-old male. He was playing basketball at home. He twisted his knee, felt a pop. It swelled up right away, had a big effusion. Dad said it looked like a water balloon, and they did nothing. They stayed home, and then eventually they came to see me a month later because his knee was clicking, and every time that he tried to go back to playing basketball, it felt like it was giving out. So they talked to their pediatrician and eventually ended up in my office. So when we examined this kid, a month later, he still has a moderate effusion, fluid inside of the knee joint. He's tender along the medial and lateral joint lines where the medial and lateral meniscus live, those bumper cushions between the femur and the tibia. His knee motion is a little bit limited. 140 degrees would be full, but he can only get to 120, and it hurts him quite a bit still. And if we stress his knee, if we put some varus and valgus stress on it and compress those medial and lateral compartments where the meniscus lives, he's tender on both of those. The Lockman is a little test that we can do to see if an ACL is intact, so we bend the knee to like 30 degrees and try to translate the tibia forward. And he's got no endpoint to this, which means it's a B, and 3 means no endpoint. So it just feels really rubbery, really loosey-goosey. And we can compare it to the other side in kids because they all have a little bit of ligamentous laxity. So he's a little bit loose on the other side, age appropriate, but he's got a really firm endpoint. Here it just sort of keeps on going. And then fortunately his collateral ligaments are stable to varus and valgus stress. So unlike Nick Chubb, he's got that going for him. So here's his x-rays, and when we take a look at his films, I don't have a pointer, but you can see those lines that are there. Those are the growth plates, and all of those are normal. We could have a fracture through a growth plate in a kid, and if it's non-displaced, it won't show up on these initial films. So it's important always to remember that normal radiographs do not definitively disprove that you could have a fracture, but x-rays don't show us meniscal tears or ACL tears. We need an MRI for that. So here's some sequences from his MRI, and we can see the femur bone up top, the tibia bone, and then there's the fibula, so we know we're on the lateral outside part of the knee. And the meniscus is that little bow tie shaped structure that's there in the middle. If we look at the back of it, if you sort of squint, there's a little bit of white signal that's in there. You can see that in the back part, so that makes me suspicious there's a lateral meniscus tear. If we look here, you can see that black line structure there is his PCL, and that's the way his ACL is also supposed to look, but that blob there that's in the middle is what used to be a really nice ACL probably and is no longer so nice. And if we keep coming through here, you can see that line in the back of that medial meniscus is also probably a tear there. So let's see what our radiology friends said. So they agree with me, complete tear of the ACL. They think the medial meniscus is torn. They're not so sure about the lateral meniscus, but I have a clinical exam that they, living in their basement, don't have, so I'm more suspicious about that than they am. So when we're taking care of kids, kids have growth plates, so we have to get a few other things to figure out how we're going to make decisions for them. So we actually get an x-ray of the hand. There's this cool atlas called Grulich and Pyle that out of all places in the world, believe it or not, was developed at Case Western in Cleveland, Ohio. And surgeons all over the world use this to determine the skeletal maturity of kids and how much growth they have left. So this kid's bone age matches up with his skeletal age. So we know we've got quite a lot of bit of growth left. The average boy stops growing around 16. So if we did a regular run-of-the-mill adult reconstruction on him, we'd destroy part of those growth plates, and his knee would start growing at an angle that wouldn't be so great. We also want to get baseline hip to ankle films on kids so we can understand what their alignment is before surgery, so that way we can objectively look back and see if we've done anything to change that in a way that's not so hot. So if we think about ACL ruptures overall, when we look at athletes, 22% of all insurance claims for athletes across the United States are for knee injury. And of these, 37% of those in females that are knee injuries ended up tearing their ACL, and 24% of males ended up tearing their ACL. The lowest ACL tear that's ever been reported is 5 years old. So if you guys can find me a 4-year-old with an ACL, God forbid, I hope not, but if so, we'll be able to write it up. CHOP, the Children's Hospital of Philadelphia, looked at the incidence of ACL tears, and we're seeing, I could give a whole lecture for hours on the importance of sport diversification and overuse injuries and all this sort of stuff, but as a function of the way that we're raising children nowadays, the incidence of ACL tears is skyrocketing. And from 99 to 2011 at this single institution, they found that the increase was 400% in kids that were tearing their ACLs. So this is becoming more and more common. Female soccer players are the highest risk of an ACL tear. So every time you touch a ball, it's an athletic exposure. If we have these kids that are playing on multiple travel teams, their high school team, they have practiced multiple days a week, each one of those opportunities that they're on the field is an athletic exposure. So there's 14 ACL tears in female soccer players for every 100,000 athletic exposures. So it's a really high number. When you guys see kids on the field that have a large knee effusion that's pretty immediate, does anybody have any guesses on, in a pediatric or adolescent patient, how many of those would have an ACL tear associated with that effusion? Any guesses? Who thinks it's 100%? Greater than 75? Greater than 50? 10%? So it's actually 65%. This was a study done at Pitt. So this is a good way to get insurance companies to approve MRIs. Just say, well, this kid has an effusion, it has a 65% chance of having an ACL tear. But for you guys that are there on the front lines of this is important to use to coach and say, well, this could be something going on inside of his knee. It's really important to get this looked at. So Taylor Swift was less impressed with the historical treatment of ACLs than she was with Travis Kelce's performance last night. But what we used to do not too long ago, like 2-3 decades ago, we would say, okay, well, you're young, you blew out your ACL. why don't you just like stop playing sports or wear a brace or something for the next 5 years until you're 16, and then we'll do an adult reconstruction and you'll be fine. So we know this is a terrible idea, and here's one of the reasons why we know this. This is a study that we did in Cleveland, and we included some of our friends in Pennsylvania and New York in this data cohort too, but we found that for every week that a surgery was delayed for somebody with an ACL tear, there was a 2% cumulative increased risk of them having a medial meniscus tear. So these degenerative changes, this arthritis rapidly accelerates pretty quickly out from the tear. So early intervention, developing mechanisms to get these people into a specialist is very important. And we know that doing an adult reconstruction is bad because of the open growth plates. Dan Green is a friend that's at HSS in New York, and he found that even in kids that are like 14 years old to 16 years old, which is approaching what would consider to be skeletal maturity from an age standpoint, but maybe not skeletal maturity on a radiograph standpoint, these kids can still end up with limb length differences and angular deformities, which the whole goal of doing no harm is defeated by that. So we have a bunch of different surgeries that we can do in kids based on how old they are. And if kids have a lot of growth left, we can take a strip of the IT band and sort of loop it behind the knee. And this is not an anatomic reconstruction. It's not the same as a regular ACL, but we can use that, and it sort of is good enough. The kids do quite well with that. We can also, so this is a picture of this sort of a surgery. So we take a strip of the IT band, loop it around, and just sew it down to the periosteum on the front of the tibia. And this actually does great. When this was invented, people thought this was going to be just a temporary surgery, and they found out they never had to do a formal adult reconstruction on these kids because they did so awesome. We've also more recently, this was published in 2010, so pretty recently, we've developed this technique where we can do an all epiphyseal outside of the growth plate anatomic reconstruction in kids, and this tends to do pretty well too. And then for in-betweens, if you have like 2 years of growth or less remaining, your femur is still wide open, that growth plate there, but the tibia growth plate's starting to close earlier at that point. So we can go through the tibia, leave the fixation below it, and then put which is, it's hard to do these tibial all epiphyseal fixations, but it's pretty easy to do the femur ones. So this sort of a hybrid approach tends to work pretty well for those kids. And then now, just so you know, on the horizon, we're actually learning how to not just reconstruct the ACL, but repair it. So Martha Murray at Boston and Bing Yan, who's there, have developed this implant called the Bear, where it's like this sponge in a protective matrix, and we can put it around the ACL, and you can actually grow a new ACL. So on the left there, you can see a torn ACL, and a couple months later, that ACL is totally reconstituted and grown. And the benefits of this is if we can save all those nerve endings and that proprioception that's inside of the knee for these kids, we can do a good job for them, hopefully over the long term. And we know that those in which that surgery fails, their revision procedure, the outcomes of that are the same as doing a primary ACL reconstruction. So the only thing that we lose is time. So back to the case, we scoped this kid's knee, found that he did have a true ACL tear, so we did one of those all epiphyseal reconstructions. His medial and lateral meniscus were both torn. And then the knee doesn't know what to do when it has an ACL tear. It can't heal the ACL, so it just forms a bunch of inflamed synovial tissue to try to calm it down. So we took some of that out as well. And this kid ended up doing pretty great. So tibial spine fractures are a special injury that's very rare in adults. Happens only in kids, but the ACL itself is intact, and it's pulled off of the bone. This was described by Myers and McKeever out in LA, and there's a couple different types of ways that this can tear. It can just be an incomplete tear, it can be angled a little bit, it can be pulled off completely, and our treatment decisions depend sort of on how that looks. This has been sort of an understudied injury. In 2013, there was only 28 publications in PubMed on this injury in children, really not a whole lot at all. PRISM, one of the groups that I help out with on their board, had a tibial spine research interest group that was founded in, I think, 2016. And between 2013 and now, there's over 200 studies on this. So this sort of gives you a feel of how new pediatric sports is and how we're sort of changing the way we do it. So the way we take care of these is the ACL is intact, so we can do a scope, and we can loop some stitches around the base of the ACL, around that bone piece that's there. avoid that growth plate and sort of anchor it down below the growth plate to let that bone piece heal. If we get these to heal, it's pretty great because now we have bony healing, so this heals the way a fracture does, and you don't have to rehab this the way you have to do an ACL. ACLs take about 9 months to return back to full sports. We can get these kids back to regular activities in about 3 or 4 months, so this does a whole lot better. We're going to shift gears again and talk about patellofemoral instability. When the kneecap pops out of the socket, that nice V that's there on the left side of the knee is called the trochlea. That's the home of the patella. We really like to keep it in the home. When it's sitting out there on the side, that makes us sad. So this is pretty common too. 43 of these per 100,000 people in 10 to 17-year-old kids. 25% of these can have an associated osteochondral fracture. Kids can knock a chunk of cartilage or bone off that doesn't show up on the x-ray. In fact, I had a kid come to see me last month because his grandma, who was his guardian, was concerned that he was in-toeing. She's like, he's walking around like this. And I'm examining this kid, and his knee is swollen up like a water balloon, and I can feel a chunk of cartilage moving around in there. I'm like, well, what about his knee? And she said, oh, he'll be fine. He just like tweaked it playing baseball. So I'm not so sure. So we got an MRI, big chunk of cartilage. His whole lateral femoral condyle was off. And he needed surgery to fix that. So these are these things where I think we can really influence and move the needle on public health by raising awareness of this and telling people that we can help them and prevent these bad things from happening if we get them in sooner. We know that untreated patellofemoral instability, even if you don't have a traumatic, crazy event where you knock off and shear a piece of cartilage, over time, you're just going to, this is sort of like the patella is supposed to glide, right? It's not supposed to grind side to side. So this side-to-side motion results in earlier arthritis. So if we take care of these kids early, we can prevent an early knee replacement down the road. So there's a whole bunch of measures of alignment for patellofemoral instability. None of these are particularly important or interesting to you guys, but the patella is not a simple joint. It's a pretty complex thing. And, but I think what really matters and what some of my friends have started studying is at the level of the trochlea, at the level of that groove that we have, does the patella engage? And obviously here, not so much. But there's some subtleties of the alignment that people have that some of these traditional measurements didn't look at. So people used to look at this thing called TTTG, tibial tubercle, this little bone bump that you have where your patella tendon inserts on the bone to that groove, and said, well, if it's less than 20, it's normal. So this person has a TTTG of 18, which is technically normal, but if you look at that black line on the side, that's the patella tendon, and about 30% of it's sitting outside of there. So, if this groove is very shallow, the body's able to tolerate less lateralization, less outside vectors of that. You can see here in this picture that blue patella that's on the left. It's got a nice deep V groove, so that's able to tolerate a little bit more lateralization of the extensor mechanism than that figure B one, where just anything that's off of that force vector is going to be pulling it to the outside, and the bone's not going to be able to contain it. So we published a study and found that this measurement here, just looking at that lateral ridge, that apex of the trochlea, the more that it overhangs that, the more likely you are to have a true dislocation. And we also looked at some other measurements and found that if you look at that, similar to the way other people did, this tibial tubercle bump here that sort of shows where your force vector anchors. And if we look at that bump on the femur, the more that it overhangs that, the less the patella is contained within that groove, and the more likely it is to fall the rest of the way off. And nobody used to be able to really predict your risk of recurrence of patellofemoral instability, but if we get this measurement on an MRI and somebody's close to that ridge or overriding it, they have a 72% chance of this happening again. So now we can have an informed discussion with parents and be like, you could do a year of therapy if you want, and you have less than a 30% chance of it working, or we could do a surgery now and fix it. So this has sort of helped us in the way we think about these things. So how do we treat these? We're not going to get into the big details of surgery, but step one is the patella at rest contained within that trochlear groove? And if it's not, there's two things that we can do about it. If a kid has growth left, we can actually peel the tendon off of the bone, shift it towards the center and sew it back down, and they'll heal there just fine. If they have completed growth, then we can take a wedge of the bone there, shift it over, and then we get bone-to-bone healing. So now the patella is tracking exactly where we want it to. And then we can build them a new ligament called an MPFL, your medial patellofemoral ligament. And this is basically like a tether. It's like a rope that goes from the inside of your kneecap to your femur bone, and it really just prevents it from falling out. So we can use a cadaver tendon to do that. And these tend to do really well for kids, and we limit that risk of arthritis. So you can see here sort of how we do this MPFL reconstruction, make a little loop through the patella, anchor it with a little bioabsorbable screw that turns into bone in the femur, and then their body will fill this with their own cells, and this tends to do pretty well. So one more shift in our gears is to shoulder instability. So here's another case. This is a 16-year-old wrestler. Wrestlers are like a big culprit for dislocating their shoulder. And he didn't do this wrestling, he was just doing a pull-up, and his shoulder popped out of the socket. He had immediate pain and deformity. If you have a true shoulder dislocation, you're not reducing this on your own. This is one of those things where our orthopedic resident friends have our anesthesia friends put you to sleep, and two of them are pulling on you to put this back in place. So this kid went to the ER, true dislocation, had it reduced, and he had a subluxation type event a few months earlier during wrestling, probably had a little bit of tear of his labrum, that bumper cushion around the shoulder at that point, and then made him more predisposed for this later injury. People have been dislocating their shoulders all throughout history, so Hippocrates wrote about how to do a reduction maneuver way back in 460 BC, and his approach to it wasn't too different than if you see our residents pop it into place in the ER. Nowadays, it's got to get it back in place. So this kid had limited external rotation. Most shoulder dislocations, 95% of them are out the front, and this sort of position is what puts you at risk. So if we test them this way, they feel like they're going to pop out. If we put a little bit of force on them this way and push on it while we're doing this, it's replacing the work that the labrum does and makes them feel a little bit better. He had some laxity going forward, but going backwards felt fine, so we knew it wasn't just a loosey-goosey, multi-directional instability kid. Here's our imaging, and you can see on this x-ray on the left, the shoulder belongs up, articulating there with that glenoid, and it's sort of out of place. Now it's back in its home. We're happy, but there's more to the story. This isn't just a bony injury. And if you look here, this is sort of a side view. So the ball is the humeral head, and that structure that's there on the inferior off to the right there, that is the labrum. And you can see that line that's making a triangle on the front. So that's the front labrum. It's torn off of the glenoid, the socket there. And 80 to 90% of people that have a shoulder dislocation are going to tear that labrum off the bone, and half of them can take a chunk of bone with it. And then they can also have this thing called a Hill-Sachs lesion too, which is also described by two folks here in Cleveland that subsequently abandoned ship and moved to UCLA. Don't know why you would want to go to LA from Cleveland, but they chose to. And a Hill-Sachs lesion you can see there, that's a pretty extreme example, but basically you create a crater in the humeral head where you have a bone defect that's there from that humeral head impacting the glenoid. So shoulders are pretty inherently unstable joints. So this is one of those opportunities where you can say, well, it's popped out once, maybe you should get this looked at. This is not a normal thing. Shoulders don't have like this big bumper cushion like that training wheels golf tee there on the right. That's more of like what a shoulder joint is like. The glenoid is a very unstable structure, and the labrum's job is pretty significant to hold that shoulder in place. This bro, Blundell Bankert from London in 1938, talked about the Bankart tear, when you tear that front inferior labrum off. And he was very confident that these should have surgery. He said nobody could possibly doubt that the only rational treatment is to reattach the capsule to bone. Seems pretty reasonable, but we didn't know until about 10 years ago that we should offer surgery to first-time dislocators. This was a very controversial thing. We know in terms of immobilization, if you're going to try to treat it without surgery, there's no benefit of keeping kids in a sling for a long time. It just doesn't make a difference. So 1 week in a sling and off you go, do some therapy, try to ramp back up, won't make a difference. Age does make a difference, though. So if you're skeletally immature, if you have more ligamentous laxity, your risk of this happening again in some studies is as high as a little bit more than 50%. In some other studies that probably didn't have the long-term follow-up that they needed, they said it was 0%. And, but if you're skeletally mature, it's not so great. So the literature now shows that these kids that are done growing, one first-time shoulder dislocation, your risk of this happening again and again and again, and eroding that bone and giving yourself arthritis. And we know untreated shoulder dislocations have a 29x risk factor of needing a shoulder replacement later in life. Your risk of this being your future is 69 to 100%. So here's a systematic review that was done, and they found that redislocation in those that had surgery was only 7%. So, you know, if we think about this from a common sense standpoint, how many of you would say, well, if this treatment that has a 30 to 100% failure rate, how many of you would say we should try this first, or we should do something that has a success rate and operate on these people if we have a success rate that's over 90%? So I tend to offer surgery. Obviously, it has to be a patient decision, depends on the sports you want to go back to, but I tend to offer surgery to these first-time dislocators. And the way that we fix these is with a scope surgery, so just 2 little incisions, one in the front and the back of the shoulder, and we can put the camera in the back and put some tools in the front. When you just take some stitches and put them along the labrum and bring it back up to its home, if we think about this in like 3 dimensions, if here is the shoulder socket and here's the labrum where it's sort of supposed to live, it sort of falls down here like this. So we just free it up, bring it back up to here and sew it down and anchor it back into place. Kids are in a sling for 6 weeks. We start their motion and they get back into things. These tend to do pretty well. So you can see there on the bottom, that's a nice bumper cushion of a labrum that had previously fallen off and we wouldn't be able to see. Sometimes they'll have some bone loss in the back where that humeral head gets impacted. We can sew the rotator cuff into that. So it limits a little bit of motion this way, but it prevents that crater from engaging and forcing the shoulder out the rest of the way. And sometimes they lose bone on the front too. And when this happens, we can take the coracoid, that little bone process here, cut it off and use a screw to put it down on the front to augment some of that bone and help hold that in place there. So these are more salvage procedures. It's nice if we don't have to get to those. And in this case, we were able to get that labrum that was torn, and we can sort of see right there. So that's the humeral head, the ball up top on the right. There's the torn labrum. There's the glenoid there. And we put some stitches in the bottom of it. Now this kid has a nice stable bumper cushion. Going to do pretty well. So in terms of returning to sport, there's a lot of factors that we have to consider. So step 1 is the health status of the kid. So what are their actual symptoms? What past injuries or medical problems have they had? What's their functional state? What are their physical exam findings? You know, kids that have a true knee dislocation like Nick Chubb's injury, that wasn't a patella dislocation, that was a knee dislocation. That actually has a pretty high risk of having a popliteal artery injury and like losing your leg. So somebody with an injury like that has to go to the emergency room, has to get assessed. It's different than somebody who popped their kneecap out and it just sort of pops into place on their own. Those kids, you know, we still want to work up, but it's not a potential medical emergency. And then we want to think about what type of sport kids are going back to. Are they playing a position that's going to put them at further risk of injury? How are they able to compete? How are they able to protect? And then there's some decision-making factors too. I'll see kids all the time with like small non-operative fractures that we'll put into cast, and they all ask, can I go back and play football? It's like, well, you can, but do you want to? Do you need to? If you have a scholarship on the line, then maybe you should go out and play. But if you're like a 8th grader and you have the potential for some 300-pound 8th grader to fall on you and give you another both bone forearm fracture at the end of the cast, maybe that injury risk for your future isn't worth skipping a month of football season and just letting your bone heal. So a lot of factors, and there's a lot of value-based things that we have to do in the way that we consider returning to sports. And it's not just the injury and the physical exam itself. There's a lot of stuff. I hope some of this was useful to give you guys an overview of some of the things that we think about and some of the things that happen down the pike from when kids present from the trauma to what their long-term outcomes are. I'm happy to take any questions that you might have. Nothing's off the table. That's my email address. If I can help you with anything at all, any questions, feel free to reach out too. Thank you, guys.
We did have We do have a couple of questions that were sent in. I'm going to combine a couple of them because they all kind of go to the same thing of at what age or are there strengthening things that kids can do to help prevent these knee injuries? And also with meniscus injuries, can they heal on their own?
So those are great questions. So in terms of strengthening, I don't think that we necessarily want kids doing heavy lifting, poor form, but the thing that we can't start weight training on younger kids is sort of an old wives' tale. So I think the stronger that your quad mechanism is to prevent patellofemoral instability, the stronger that your hamstrings are. We know that for ACL tears, if we have a specific training program and if we have a trainer working with kids to train their brain how to use their knee, we can statistically significantly lower the risk of an ACL tear. So these are all interventions that we can do. It'll be, sometimes we'll see in our clinic a kid that comes in and is like, everything hurts, I don't have an injury, but my whole lower body hurts, and oh, by the way, I just started playing field hockey. And you do a physical exam on some of these kids, and this kid couldn't safely jump onto a shoebox, and she's out trying to play field hockey. So I think, it's never too early to encourage kids to have good musculoskeletal health. So that's an important thing. Meniscus tears, for the most part, can't heal on their own. They almost always need surgery. There are some rare cases, though, in the setting of an ACL tear, when you have that giant hemarthrosis and blood inside of the knee, where we will see on an MRI what looks to be a true meniscus tear, and we'll see on the scope what was a real meniscus tear, but because it was relatively stable and all that blood got a bunch of healing factors inside of the knee, they were actually able to get enough healing around it in a kid in a specific meniscal zone that sometimes these will heal in that limited setting on their own. Great questions.
And one more that came through about larger kids. You mentioned bigger kids, an example given of a 14-year-old, 6'2", 180. Are they more prone to joint injuries because they haven't caught up to their size?
I think that if we think about this from a biomedical equation standpoint, if you have a larger person with a larger amount of mass moving around, and they are younger in their brain development in terms of their proprioception, their ability to understand their body in space, there certainly is a potential for them with growth plates that are open, more mass, less control, that they can have some injuries that are pretty significant. And I did a shoulder scope on a kid last week who was a true freshman in high school. He was 6'5", 315 pounds, all muscle, giant kid. And this kid, his family sort of belabored it too, and they bemoan the fact that everybody's targeting him because they think he's a big guy and he has control and he's going to be this elite person in the future. So I think there's a lot of factors that weigh into it. We can't change the bodies that we have necessarily in terms of our growth and development trajectories. We can just keep them healthy, but I think as you have some of these bigger kids that have the potential to be superstars, we can't just release them into an uncontrolled environment without giving them the training that they need to keep them as safe as anybody else too, because they're still just kids.
I'd like to thank you. That was
Thank you.
an excellent review.